See my slides?
Yes, sir.
Okay. Right. So sorry for the hiccups. And I think Ebola is specifically we have, two similar viruses in epidemiology, the Marburg viruses and the Ebola viruses. In Ebola viruses, we have the four different types. That is the Bendigo Bugio viruses, the Sudan Ebola virus, Thai Forest Ebola virus, and the Zaire Ebola virus. The major two countries which are affected are the Democratic Republic of Congo, and specifically the Ituri district which has been affected, and the other country which is affected is the Uganda. And if you see this slide, how the travel is so easy, though other countries are not affected, but you can see the travel, because air travel is so easy across the world, the spread can occur. The present statistics says that as of 1st June till yesterday, there are 1,262 suspected cases, 291 confirmed cases, 241 deaths, and two countries are affected. So if you see the outbreak timeline on 14 May 2026, the first Ebola-like deaths reported in Ituri province, that is the Democratic Republic of Congo, and 15 May 2026, Bundibugyo virus confirmed by the INR lab. DRC and Uganda declare an outbreak. Uganda reports its first imported case in Kampala. 16th May, 246 cases were so rapidly it is spreading, and 80 deaths are already trailed. 17th, the WHO declares as an emergency, and CDC issues level 3 notice. By 29th May, 1,262 suspected cases. And as 1st June, I think already gave you the statistics that there are already 240 deaths which have occurred. Very important is that the healthcare and the humanitarian impact. The healthcare workers, basically patients come with, so before the outbreak, patients just come with symptomatic treatment as just an acute febrile illness, and the healthcare workers are not, they're clean bold there because they are not aware about such an outbreak is going to happen. So they just come with symptomatic, fever, loose motions. So, the healthcare workers, handle them. So the first two deaths which happened were of the healthcare workers. The healthcare worker were among the first confirmed index cases. Cases reported in Bunia, Mampara, and Mogbula facilities. Two healthcare workers were the initial deaths which happened in Uganda, confirmed by 25th May. The MSF mobilizing Ebola managements, more than 900 have been affected. MSF is Medicine Sans Frontiers, which mobilize this, and shortages of PPE, US funding cuts the US aid. But in humanitarian context, if you see Ituri, 1.9 million people in humanitarian need, 2,73,400 internally displaced persons, amplify spread, 5,800 protection incidents, armed insecurity limits access for response teams, and high cross-border trade between the DRC and Uganda facilities spread. So far, there are 10,000 patients treated and 906 suspected cases. So MSF has deployed team across Uturi, historically treated as one-third of the all of the WHO confirmed Ebola cases globally. If you see countries which were affected were that is the Democratic Republic of Congo, where 264 cases, 15 confirmed in North Kivu and South Kivu. Then in Uganda, 9 confirmed cases, 1 death which has occurred. So another thing is very important is that the mortality compared to Ebola, which is 60, Ebola is 60 to 90% mortality, whereas in this Budgoya virus, it is roughly around 30 to 50%. So in Uganda, if you see 9 confirmed cases, 1 confirmed death, and if you see the global alert and border nations, Germany, 1 medically evacuated American, Berlin, the name, Kenya, US quarantine facility established, India emergency response plan because Kerala 21-day surveillance, Hong Kong quarantine facility set up, travel alert, Israel travel advisory, no confirmed cases, Brazil, Chile, Colombia, FIFA World Cup alerts, DRC match. So people from DRC are going to play the match, and that is the concern. If you see the rising cases, which is demographically seen, the case fatality rate is roughly around 30%, which is slightly much lower than the Ebola virus what we see. And by 1st June, you'll see that number of cases suspected and the mortality, which is according to the case region. If you see the pathogen profile about the Bundibugyo Ebola virus, so difficult to pronounce also. Bundibugyo. So B Ebola virus, I will say Bundibugyo Ebola virus. The virus specific is Bundibugyo Ebola virus, one of the four species causing human diseases, first identified in 2007 in Uganda. Transmission is direct contact with blood and body fluids, handling bodies of deceased, high risk, not airborne, droplet or contact spread. So it's very important to know that unlike H3N2 or COVID, it is not airborne or it is not droplet spread. So it is neither contact spread. So vaccine status is it is specifically spread by body fluids. Vaccine status, no licensed vaccines available. Unlike Ebola, we have two vaccines, that is Arvibo and one more mRNA virus vaccine which is there, which works on Ebola, whereas there is no licensed vaccine for this. The previous outbreak was in 2012, again in Democratic region of the Congo province, and the case fatality rate was 25 to 36%, which is lesser than the Ebola. Ebola is around 60 to 90% and smaller outbreak than the current 2026 event. But a 2026 event, the outbreak is much, much bigger than the earlier outbreak. Treatment, no specific antivirals approved, supportive care only. Monoclonal antibody candidates are in trial, and symptoms will come in detail about this. I think if you see the global response, politics and funding, WHO, MSF, CDC, everybody is awakened and helping this. This is the historical context about the major Ebola outbreaks which have happened over a period of years. If you see 1976 DRC against Zaire, 280 case deaths which have occurred. In 2007, Uganda again that is BDBV, this outbreak which was there, again 37 deaths. Again 2012, similar 31 deaths. But the biggest was in Zaire in 2014 to 2016 and 2018 and 2020. You'll see 11,000 deaths. And the majority of the NEGM articles are coming from between 2014 and 2020. So if you Google NEGM Ebola, you'll get around at least 40 to 50 articles on Ebola between 2014 and 2020 and writing about the various experiences about, various clinical features and everything which is there. And in 2025, we again, it is nothing new. I think every 3 yearly, 2 yearly, and now it has become more frequent that we have some outbreaks. And presently in 2026, if you see the BDBV, you see the compared to 2007, 2012, this is a much, much larger outbreak. And 2026 outbreak is already 6 times larger than of 2007 and 2012 outbreaks combined. The speed of spread alarming is it's alarmed WHO. The key difference is the dominant 2014-2016 Zaire strain has Arvibo vaccine, whereas Bundibugyo has no approved vaccine, making the 2026 outbreak uniquely difficult to control. So it's a major concern. So what about Ebola virus? Ebola virus is a member of the Filoviridae family, has 5 distinct species: Zaire, Sudan, Thai, Forest, Bundibugyo, and Reston. Known for causing severe hemorrhagic fever, Ebola has caused several significant outbreaks in Africa, with the 2014-16 West outbreak, where there were 28,000 confirmed cases and 11,000 deaths. Natural hosts of Ebola virus are fruit bats. Transmission occurs by contact with excrement or human consumption of bats or through antelopes and great apes consumed as bushmeat. Human to human transmission occurs through direct contact with blood, bodily fluids, or tissues of infected individuals, and vertical transmission from mother to fetus, resulting in stillbirths or miscarriages and live births with death within 19 days of life. Very important, it is not spread by direct contact, it is not spread through droplet, and it is not spread airborne. So this is something important. So I think everything anyway, gloving, I think before examining any patient would be, I would say, in otherwise also I think is at least I use gloves for examining any patients who whether it's a contagious or non-contagious disease. So this is a nice diagram from NEGM again, which talks about pre-outbreak. The reservoirs are the fruit bats. Its zoonotic transmission intermediates host are the amplifying host are the antelopes, or the chimpanzees or the gorillas. And I think these chimpanzee gorillas more are seen in the South African countries, and that's why the outbreaks are more there. And then it spread to the index case by handling these dead animals or whatever way the contact occurs. Outbreaks occur from one person to other person is through, usually by bodily fluids or, deaths which people handle during the burial and all that. And so I think important post outbreak, what is the risk surveillance, and we'll talk about this in detail. So coming to this flevovirus taxonomy, where Bundibugyo sits, where does it sit? So if you see that Zaire Ebola virus, the case fatality rate is 60 to 90%, and there is a vaccine which is available, that is Arvibo, and the treatment is also available for this Zaire Ebola virus, that is INVASIVE and Ibanga. So it's a monoclonal antibody which is available, which can work against this Zaire Ebola virus. Coming to the Thai forest virus, it is non-fatal and hardly any cases have been reported. Whereas Sudan Ebola virus, again the case fatality rate is 41 to 65%. Whereas the vaccine, again, no licensed vaccine, treatment, partial treatment with the same in Mezeb, and also partial treatment with Ibanga monoclonal antibody. What about the Western virus? Again, the case fatality rate 0% in the humans. And the next one is the Bundibugyo virus, where the case fatality rate is around 30 to 50%. If you see this, this is a nice table which describes between, distinguishes Bundibugyo versus Zaire versus Sudan. Because Zaire, the mortality rate is, if you see, 60 to 90% case fatality rate, whereas the Sudan is around 41 to 65%, whereas in Bundibugyo is around is around 30%. So the mortality rate among the other viruses is much lesser compared to the Zaire and the Sudan. Another thing is very important is the incubation period is the same for all of them, 2 to 21 days. Hemorrhagic frequency, if you see Zaire, hemorrhagic frequency is very common. Even in Sudan, it is common. But whereas in Bundibugyo, it is predominantly the GI bleed which occurs. It is less frequent, common, but it is GI dominant, predominant clinical features. If you see the glycoprotein homology, it is 55% of, Sudan is 55% versus of Ebola, whereas similar distinct epotypes of the Bundibugyo virus as well. If you see the licensed vaccine, none for Bundibugyo. Compared to Zaire, we have this. Whereas again, licensed monoclonal antibodies we have for Zaire and to a certain extent for Sudan, but none for Bundibugyo. So Bundibugyo, we don't have any monoclonal antibodies, neither we have any vaccines, and cross vaccine protection unlikely as of now. And reservoir for all of them is fruit bats, and I think this human to human spread is similar in all of them. It is direct contact with fluids. So this is the way how you can differentiate. Though the mortality is less in Bundibugyo, it is spreading very fast because there is no treatment, there is no vaccine available compared to the Zaire Ebola virus. If you see the viral tropism, what is the pathogenesis of this Bundibugyo virus, or what is the pathogenesis of Ebola viruses, is that viral tropism triggers a dysregulated immune storm leading to systemic organ failure. And the pathology of the flow network is viral entry into the mucus or broken skin, causes infection of the macrophages and dendritic cells, causes the cytokine storm and the high viremia, causing both coagulopathy and endothelial dysfunction, causing a hypovolemic shock and multi-organ failure. So this is how, in simple or short, pathogenesis of these Ebola viruses occur. The clinical reality is that dramatic hemorrhaging is possible but not universal. It is an enveloped single-stranded negative sense RNA virus that targets the immune system's primary sentinels. And the mechanism of death is most fatal cases succumb to profound hypovolemic shock and multi-organ dysfunction syndrome driven by endothelial injury and not excess exsanguination. If you see another pathophysiology, why Bundibugyo virus behaves differently from the other Ebola viruses is glycoprotein divergence. The Bundibugyo virus glycoprotein shares 54% homology with the Ebola viruses, distinct receptor binding domain epitopes, neutralizing antibodies to Ebola viruses. GP do not cross neutralize Bundibugyo virus with reality, explains why vaccine and monoclonal antibody failure. The hemorrhagic pattern is less hemorrhage predominantly in the Ebola virus. GI manifestations that are predominant manifestations for Bundibugyo virus, and coagulopathy is there. Whereas immune evasion mechanism replicates in monocytes and dendritic cells, suppresses interferon alpha and beta early, causing a cytokine storm. Organ involvement involves the liver, adrenal, kidney, and encephalitis, as well as causes hemorrhagic pneumonitis. Relative pathogenesis: Bundibugyo virus, least pathogenic human Ebola virus. Case fatality rate is roughly 30% compared to much lesser than one third of the other Ebola viruses. Prognostic markers: high viral load, cycle threshold will be less than 22, worse outcome. Elevated CPK will be causing muscle necrosis. Bilirubin more than 10 will cause hepatic failure. And survivors of anti-Bundibugyo virus antibody titers higher, falling lymphocytes, a poor sign. Now, very important, this slide, which talks about patients becoming contagious only at symptom, which I spoke to you before I started my presentation. Patients becoming contagious only at symptom onset, triggering a rapid clinical decline. So initially, I think unlike your H3N2, H1N1 or COVID, where the patients were contagious 2 days before they develop the symptom, here the patient is contagious only after the symptom onset. That is, phase 1 is incubation period, slight silent viral replication, patient is strictly non-contagious, casual proximity is safe, and highly contagious when the patient develops early syndrome, that is fever, severe headache, muscle pain, profound weakness, and phase 3 is severe progression, vomiting, massive diarrheal fluid loss. We have a better slide than this to explain the clinical profile. So if you see, they will come with conjunctival injections, uveitis, uh, nausea, vomiting, dysphagia, maculopapular rash, hepatic dysfunction, pulmonary edema, and bacteremia. Sometimes they can develop translocation from the gut. Psychologically, CNS, they can develop encephalitis. They have headache, arthralgia is a very non-specific complaint, but sometimes they can have really severe myositis, and because of dehydration they can develop renal dysfunction, endothelial dysfunction, coagulopathy, and diarrhea. This is how the clinical features, but these are very common clinical features to any other any acute febrile illness in India will have similar medical similar clinical features. And it's very important, how would you differentiate Ebola or Bundibugyo virus from our Indian so much of tropical fevers which we see in our clinical practice. So Ebola virus disease clinical progression: early it is febrile 0 to 3 days, which just comes with fever, malaise, fatigue, body aches, which any of the dengue, chikungunya, malaria, lepto, scrub, or even enteric fever will have. Gastrointestinal symptoms 3 to 10 days, primarily epigastric pain, nausea, vomiting, diarrhea, which again any of these viruses in the first less than 7 days would have. Associated persistent fever, asthenia, headache. A lot of these common illnesses would be seen in our tropical illnesses. Shock or recovery 7 to 12 days. Shock, diminished consciousness, coma because of encephalitis, and late complications are GI hemorrhage, secondary infection because of translocation from the gut, meningoencephalitis, and persistent neurocognitive abnormalities. Infectiousness increases progressively from symptom onset to late complications and continues post-mortem. That's very, very important. So Ebola virus, I'll come to a clinical case. Uh, this is a case made where the clinical vignette is: patient is a 35 years male. He returned from an Ebola affected region, attended a funeral, and had contact with a symptomatic relative. Presentation is: he comes to you with 3 days of fever, vomiting, diarrhea, myalgia, and weakness. Examination: he's got tachycardia, conjunctival injection, mild rash, abdominal tenderness, and no active hemorrhage at this juncture because just day 3 of the illness. So the main thing is critical decision is what is your first action in the emergency department. So this patient has come to you. So what is your first action in the emergency department? So I think the correct action would be isolate immediately and notify infection prevention public health. Low incidence does not equal low operational importance. So this is very important because low incidence in our country does not equal low operational. I think we should be alert, we should be doing our job, and we should be cautious and alert to see that every patient with high febrile illness, usually we examine them bare and see that you use gloves during examination if possible. So rapid recognition is very important. Missing early cases expands outbreaks. Early Ebola often presents as a non-specific febrile illness, as we discussed earlier. Do not wait for the hemorrhage. This is alert orange containment line. Direct contact risk. Transmission occurs through direct contact with infectious body fluids and contaminated materials. I think very important for our healthcare workers, the PE staff to do, they have to be well trained. I think a good training is very, very important. I think we should be having universally similar training whether there is a Ebola outbreak or there is no Ebola outbreak. I think we should be, because you never can predict what outbreak can occur, what has happened in Sudan. We can have a different outbreak in our country. So it's very important that I think everybody should be using the standard precautions. Very important. Unprotected healthcare workers are at prime risk, and the most important is the PE staff, which will be at most important at the people will be at more. So amplification danger, unprepared emergency departments, ICUs and lab departments serve as outbreak amplifiers when routine flow is not bypassed. So I think all this is very important. And so low incidence, again I say, does not equal low operational importance. So I think we have to be alert irrespective of whether the outbreak has happened in another country, because we'll be surprised one day to get this. So filovirus systemics and the zoonotic spillover. The family is filovirus. It's a negative sense RNA enveloped virus. Ebola disease represents severe systemic infection driven by a high viral load, leading to endothelial injury, unchecked inflammation, and multi-organ dysfunction, which we discussed how the pathophysiology happens. I think this slide on the right hand side also we have discussed about a fruit bat reservoir, wildlife, the antelope or the chimpanzees being the intermediate host, and then spill over to human case, and then human to human household transmission. Transmission is exclusively contact based during symptomatic phases. The reality is how it spreads requires direct contact with blood or body fluids of a symptomatic patient, unsafe burial practices, unprotected caregiving, needle stick exposures, contaminated surface equipment, and the myth is how it doesn't. Ebola virus is not airborne during routine care. It is not transmitted from person to person just by contact, and it is not neither airborne and neither it is droplet generated. So aerosol generating misconception lead to dangerous overreaction, staff panic, or underreaction, ignoring contact protocols. Asymptomatic transmission is not the clinical concern. So this is something good news, that it is not airborne or it is not droplet and it is not contact to contact. It is only on the left hand side of the slide what you will see, that is the way it spreads. So protocol based PPE and meticulous isolation from a complete shield against transmission. The difference between the PPE in Ebola or Bundibugia virus is that you have to cover the face, the neck, and you have to cover your normally. I think in COVID we were at times later on we were not covering our shoes, but I think you're covering completely, including the neck, face shield, and even the shoes and shoes cover. Everything is very, very important. That is the difference, and double gloving. That is the difference between Ebola viruses and what we did in COVID. So hemorrhage is not required for suspicion or diagnosis. So we should not wait for hemorrhage to occur for suspicion for a diagnosis. Very, very important. So if you see the incubation phase is day 2 to 21, entirely silent. Early onset phase, highly non-specific, marked by fever, fatigue, myalgia, headache, and sore throat. Ebola initially mimics routine febrile illnesses. Action must be taken here long before severe phase bleeding occurs. This is more specific for those countries, but I think we should be on a high alert in our country as well. Day 10, day 14, later phase, there is gastrointestinal systemic escalation marked by vomiting, diarrhea, abdominal pain, and rash. And in severe phase, late complication is marked by bleeding and hemorrhage. And this is how the progression occurs clinically over a period of time in a patient with Bundibugyo virus or a Ebola virus. Now, exposure history immediately shifts the diagnostic pathway. So, once there is an exposure history, that does not mean that the patient 100% has got a Bundibugi virus or Ebola virus. I think do not shift your clinical judgments what is more prevalent in India or in Mumbai or in Pune. So, I think we still have to rule out malaria, dengue, typhoid, viral hepatitis, scrub typhus. We have to not miss on leptospirosis. We should not miss on respiratory viruses. I think that's very, very important. Apart from that, you can think about Ebola, but first rule out common things which occur in India rather than just shifting because just because a patient has come from there does not mean that and he gets some low grade fever. Of course, you have to be very, very cautious. Isolate him is very important, but don't forget the common things which occur in our country because in a febrile traveler from an affected area, the pretest probability changes instantly. Epidemiology supersedes and we forget about the common things, and the patient may succumb because of a treatable cause which is there in India. So epidemiological exposure combined with a compatible syndrome dictates immediate isolation. So clinical syndrome, fever or unexplained hemorrhage, sudden onset of severe fatigue, myalgia, vomiting and diarrhea, which can happen in any of the tropical illnesses. But plus, if there is a epidemiological risk in last 21 days, travel or residence in a known active outbreak area, direct contact with a suspected or confirmed case, exposure to bodily fluids during medical caregiving, or burial practices, direct exposure to infected animals or bats, and then you have to activate isolation and public health notification. So this is very, very important part of this Ebola. The first 15 minutes, how would you act in your emergency department is stabilize safely while limiting staff exposure. Secure the zone, place patient in a designated isolation area immediately, strictly limit the number of staffs in the room, document exposure history carefully and discreetly, protect the team, don appropriate facility protocol driven PPE before any patient contact. So the PPE in COVID and here is different because you have to have a face shield covering the neck as well as what we used to do earlier in COVID. Completely, that is same thing what we have to do here. And as we came to know, COVID is not so much dangerous. We started not wearing shoe covers, not wearing just triple surgical mask was good enough then subsequently, but that doesn't hold true here. Activate the network, notify the infection prevention, laboratory medicine, and public health immediately. Focused assessment, perform a rapid non-invasive clinical evaluation, vitals, hydration status, mental status, bleeding, abdominal symptom. Do not improvise. Avoid all unnecessary procedures. Example, routine blood draws before the formal isolation pathway is convened. First, isolate the patient and then do all the necessary things which are required. Don't do unnecessary things before and then isolate the patient. First, isolate the patient and then do routinely what you want to do. So if you see the differential diagnosis, 1 to 3 days, you will have so many. I think we have discussed. Very, very important. Very, very important is apart from what we discussed about malaria, typhoid, dengue, scrub, leptospirosis, meningococcemia, viral hepatitis. Very important is Congo, Crimean Congo hemorrhagic fever. I think this is something which we have to know. So differential diagnosis, the viral hemorrhagic syndrome approach, consider Bundibugyo virus in any patient with fever, travel to DRC, Uganda 21 days, hemorrhage, myalgia, unexplained death, all that. But I think let's talk about Crimean Congo hemorrhagic fever. I think this is something which is very close to Bundibugyo or Ebola virus. I think this is something which we require to know about CCHF, and this is very prevalent in one of our common states in India, and that is Gujarat. If you see in Gujarat, my fellow, she removed all the statistics for me. In 2011, there were five cases, four died, one survived. This was in Ahmedabad. In 2012 to 2015, sporadic cases occurred in Ahmedabad, Amreli, Patan, Kutch. In 2013, Amreli, nine cases, two deaths. In 2016 onwards, it is endemicity of Crimean Congo hemorrhagic fever is established. In 2019, just few years back, there were 34 cases, 17 deaths. Why Gujarat? Because of the high density of cattle, buffaloes, sheep, and goats, and it is transmitted by hiloma ticks, extensive animal movement, close human to livestock interaction. So that's important about Crimean Congo hemorrhagic fever, which is now endemic in Gujarat. So I would like to speak about something which is very common to Ebola and Crimean Congo hemorrhagic fever. Symptoms cannot differentiate between Ebola and Crimean Congo hemorrhagic fever. It is abrupt fever, profound weakness, myalgia, severe abdominal pain, vomiting, diarrhea. Bleeding is not universal. Do not rule out viral hemorrhagic fever due to an absence or early hemorrhage. Ebola is bleeding may appear late. Crimean Congo hemorrhagic fever is classically prominent earlier but can still be entirely absent. If your exposure history is the only valid bedside differentiator, think about Ebola. If somebody is coming from Sudan or from you from the Congo Valley, think about CCHF if there's a tick bite or tick exposure, livestock handling, or animal husbandry. So this is about one. Two is divergent transmission vectors dictate the risk. Symptomatic human infectious body fluids, direct contact to new human host, whereas here it is the livestock, animal tissues, and the human host. If you see the difference between Ebola and CCHF, the clinical course is more or less the same, and the diagnostic test is, I think, depending on where the patient is coming and what exposure he had. In Ebola, both of them don't have any approved treatment except for Ebola. But for Bundibugyo, we do not have any specific treatment, and so is for CCHF. But I think we should keep in mind, urgent bedside management protocol is important, and sample collection, definitive diagnosis requires RT-PCR executed under rigid biocontainment. So I think apart from our common tropical illnesses, do not forget about patients maybe traveling from Gujarat to Pune or Mumbai or anywhere, and don't miss out on CCHF. Presently, there is no outbreak going on of CCHF, but it is now endemic in Gujarat. So, clinical bedside sample collection, the timing caveat: tests performed too early after symptom onset may yield false negatives. If clinical suspicion remains high based on the epidemiology, repeat testing is mandatory. The barrier: physical biosafety containment. You require level 4 biosafety. High risk zone, maximum biosafety laboratory diagnostic processing. The gold standard is RT-PCR of the blood is a principal test for diagnosing living patients. Subsequently, after 1 month, you may get IgG and IgM, which can remain positive for a much longer time, more than a year. So I think RT-PCR presently is a test for, again, for CCHF or Ebola. The golden rule is no symptom pattern is definitive, laboratory confirmation is mandatory. And BMJ guideline is if the exposure history is unclear and either diagnosis is possible, Ebola and both should be run at the same time. I think we have discussed this. So, synthesize viral hemorrhagic fever triage diagnostic algorithm, patient's presence with abrupt fever, severe weakness, myalgia, conduct exposure history. If there's a travel, then suspect Ebola, and so on. So, I think I'll go through this slide and I'll come to this diagnostic algorithm. Again, same thing. I think if somebody's traveled with similar history, and rule out all malaria, tropical illnesses along with. First thing is isolate the patient if the patient is traveling from this region and come to you with fever, and then do all the tests. The containment zone requires meticulous standard and transmission precautions like patient zone area, containment line, and I think single patient room or dedicated isolation unit, restricted entry points. I think all this is practically, though looks easy, but practically impossible in any of the hospital, like even for Lilavati or Dinanath Mangeshkar Hospital or Pune, any hospital. To begin with, I don't think we have such facilities unless we create one if we have suspicions. So high risk moments, doffing is very important, specimen handling very important, waste management important, patient transport important, and infection control practices using 2% hypochlorite solution for cleaning the floor is very important. So aggressive, coming to the treatment part now, aggressive support care should start early and be protocolized. Pillar 1 is resuscitation, aggressive fluid resuscitation and electrolyte replacement. Pillar 2 is physiology, oxygen and continuous hemodynamic support. Pillar 3 is symptom control, give antiemetics, antidiarrheals. And pillar 4 is vigilance for shock, acute kidney injury, hepatic injury, electrolyte derangements, and bleeding. So supportive care saves lives. ICU level care is frequently required for severe disease. So there are 4 pillars which we require to get patient to a successful clinical outcome. Early intensive supportive care drastically alters the trajectory of survival. Fluid and electrolyte, because it's predominantly Bundibugyo virus is GI, they have a lot of loose motions, vomiting, and hydrating them well is the most key to the patient's clinical getting better. So delayed recognition is the most critical modifiable risk factor, hypovolemic shock, and I think we spoke about how multi-organ failure, acute kidney injury, secondary infection, neurological decline can occur. So clinical preparedness is a protocol and not an improvisation. So very important, clinical preparedness is a protocol and not an improvisation. Needs triage, emergency department needs implemented triage scripts, stocked isolation cards, and immediate staff training. Inpatient needs PPE stockpiles, laboratory needs to define specimen workflows, transport and how safety the transport should be, and of course the administration should come actively into the play. The key message is readiness reduces staff anxiety and response time. Predefine your safe transport and referral pathways. Coming to the treatment part, apart from isolating hydration and all that, because there's no specific treatment, but for Bundibugyo virus, if you see remdesivir, the mortality, as I said, 30 to 40%, 50% is the mortality. So if you give remdesivir also 50% mortality, that means zero benefit. When against the control, which was around 50% mortality, zero benefit. That means the mortality of giving remdesivir or not giving remdesivir doesn't help at all in Bundibugyo virus or any of the Ebola viruses. Whereas for Ebola viruses, that is Zaire, if you give the monoclonal antibodies, the mortality is much lesser. Unlike the Bundibugyo virus, there is no specific treatment for that. And I think infection prevention and control is very, very important. Pre-requirements, BSL 4 level for all Bundibugyo virus contacts, full confirmed high-risk procedures, full PPI should be trained, same doffing and donning the same way what we used to do it. And very important is safe burial practices, direct contact with body fluids. Anyway, we don't have Bundibugyo virus in India, but we require to know all this is very, very important. Now, coming to the vaccine, after treatment, just hydration is a treatment, and overall looking the hemodynamics, as there is no vaccine and no monoclonal antibody for Bundibugyo virus. If you see the for Ebola virus, we have the vaccine as well as we have the monoclonal antibodies. For Sudan virus, we don't have any FDA approved monoclonal antibody, neither we have FDA approved vaccines. And similarly for Bundibugyo virus, you'll see there is no FDA approved monoclonal antibody and there is no FDA approved vaccines. So the key insight is medical literature often conflates Ebola as a singular disease, but precision is operationally vital. So vaccine effectiveness, this was a study where 265,000 people were enrolled meaning ring vaccination, that is to cause the herd immunity. And normally the onset vaccine efficacy is derived by day 10. If you see DRC ring vaccination, cases occurring within days of vaccination predated explained, and disease incidence fell sharply around day 10, consistent with the immune response of the vaccine, which was Arvibo vaccine which was given. So 5 practical rules for Ebola preparedness and bedside management. Think Ebola, always link fever to relevant travel. Isolate immediately. Never place a suspected patient in a routine ED flow. Protect the team, support early, and escalate instantly. Rapid self-test. Is hemorrhage required for suspected Ebola? No early IMSOR testing. Now, coming to whether the viral persists in the person for a long time, the Ebola viruses. So viral persistence in immune privileged sites complicates long-term survivorship. It is persists in the ocular fluid, it persists in the CNS, and it persists in the testis and semen, and it is also transmitted to the breast milk. So the Liberia cohort data confirmed that recovery does not end at a hospital discharge. Clinical sequelae, survivors experience persistent symptoms, severe fatigue, just like post-COVID syndrome. And sexual transmission risk, Ebola RNA has been detected in the semen of 30% of tested males with persistent documented up to 40 months post-illness. Public health mandate requires integration of ophthalmologic follow-up, specialized sexual health counseling, and long-term reintegration clinics. So sexually transmission through semen has been identified up to 19 months. However, live virus has never been isolated and thus the prospect of transmission has not been established. This long-term persistence provides an opportunity for the Ebola virus from survivors even from official end of the outbreak. Now, persistence of Ebola virus after the end of widespread transmission in Liberia, they found that same thing, 19 months, 330 days, and there was a increase in musculoskeletal system in the Z-map group. So breaking the chain of transmission requires a synchronized multiple disciplinary system, early isolation, laboratory support, contact tracing, safe burial practices, and ring vaccination. Coming to my few of my two, three last slides, just a question, which diagnostic test is the principal method? Is the RT-PCR, which is the, what is the standard contact monitoring after Ebola exposure is 21 days. But this is for the present outbreak is Bundibugyo virus, so your monoclonal antibodies don't work. Which Ebola species have FDO virus? It is the only for Ebola virus, not for the Bundibugyo virus. So in clinical summary, key messages is Bundibugyo virus is taxonomically Ebola but clinically distinct. It is less hemorrhage and mortality is much less, 30% compared to 90% with the Zaire Ebola virus. No vaccine, no monoclonal antibodies. Point number two. Point number three, differential diagnosis. Do not miss out on Indian tropical illnesses, what we see in India. Isolate the patient first and then send all the blood samples. Travel history within 21 days, critical epidemiological trigger. IPC failure is defining amplifier in this outbreak because there is no vaccine, no medication. That's why the outbreak is moving faster. Viral load predicts the clinical outcome. We do not have much experience about this, neither the cital threshold, because we have no zero clinical experience about this virus as of now. These are the various, apart from WHO, CDC, these are various, as I told you, various articles from 2014 to 2020 on Ebola virus, and predominantly the NEGM very well covered. I have taken my presentation from all these NEGM articles with the help of additionally artificial intelligence. Thank you for your kind attention, and I'll be happy to take on the questions.
Thank you so much, sir. I think we had we couldn't have had a better compilation of so much knowledge in just 45 minutes. Thank you so much for your efforts to disseminate this knowledge, which is very important at this time. So in the interest of the audience, I would request you to ask questions in two forms. You could either put it in the chat, or you could raise your hand. Automatically, whoever raises first would be unmuted and you could ask the question. Right now, all of you are unmuted forcefully. I will unmute you once you raise your hand. Okay. Meanwhile, I will ask Dr. Amit Dravid is also here. Maybe he can add a few comments. Amit, I'm just going to ask you to unmute.
Thank you. Thank you, Pushkar. Thank you, Nagvekar sir.
Hi, Amit.
Excellent talk. It was quite informative. Everybody is actually concerned about the emergence of Ebola and whether it will be imported to India. Going through sir's presentation, he has almost covered everything. Few points which I would like to add is uh, it is just behaving like the viral illnesses which we have seen. So first week is the viral phase. The second week starts the cytokine storm phase. which then ends up in complications. We need to be vigilant whether again we will need immunomodulator agents in the second week if and when Ebola comes to our shores will be something to watch out for. Excellent ICU care will be needed because majority of them will come with loose motions, vomiting, and severe dehydration. So our intensivist colleagues will be equally important, and hopefully we will have a vaccine soon because what I feel is the uptake of vaccine will be fast. Let's see. Thank you.
One more treatment, which is possibly is, those patients transmitting, like in COVID, no, we used to have this human plasma, those who had suffered. So that is, I think, for present virus Bundibugyo, where we do not have the vaccine, neither monoclonal antibody, possibly those who already suffered and were surviving, their plasma could be one of the modalities of treatment for this Bundibugyo virus, which has been actually looked into during the Ebola outbreaks, and it had good results.
Right, sir. Dr. Bharat, yeah, of course, he has already asked the question that do you think that it would be a pandemic like COVID? But yeah, I think given the limit of spread, non-droplet spread, I think that restricts the disease to very severely ill patients. Uh, Amit, you have risen your hand again. I'm just okay.
Hello.
Yes.
Good evening, sir. Fantastic presentation.
Walimbe, sir. Sorry.
It was Amit Walimbe, not Amit David.
Sorry.
Hi, Dr.
So,
Amit.
thank you, sir. Fantastic presentation. Got to know all the details about the Ebola, all the Ebola viruses. One concern is, can it be transmitted through flies and mosquitoes by contamination thing?
So far, no case reports as such. It is predominantly has been very clearly like with blood and body fluids only. So no vector transmission has occurred through insects. That is neither by ticks and all that. So that's very
So,
clear.
that's a good thing, at least. Because in
And
India, if it comes to India, then it may be a difficult thing to uh, protect
and
ourselves.
yeah, and then one important good thing is it is not spread by contact to contact direct person or
Yeah,
by airborne or droplets
like
like in this
H1N1 or COVID.
COVID. Yeah, and no prodromal phase.
Yeah.
Yes.
Thank you, sir.
Thank you. Thank you.
Yes. I would request Shinde sir to add his comments. Shinde sir, I'm just going to ask to unmute. Yes. Yes, Shinde sir.
I must say that Dr. Narvekar has done a fantastic job for us all internists because we are handling such patients day in, day out. And we are at risk ourselves first, then the patient's care. So, thank you very much, sir, for your phenomenal effort in collecting the material and presenting in a very short time. Uh, I Another thing that was in my mind was that. This Ebola thing, this CCHF, which you have said, have you seen any cases in Maharashtra or in Mumbai or yourself any personal experience about CCHF?
So I don't have any personal clinical experience about CCHF. It was predominantly in Gujarat, but yes, you can have a lot of people Mumbai, Gujarat keep traveling. But I personally did not have any clinical experience on the CCHF.
But
Though
the
you have added.
facilities for diagnosis are available.
So similarly, RT-PCRs for CCHF is available. I think because now it's endemic in Gujarat. Like in 2019, there were large number of cases, 34 cases, 17 deaths, and these are the reported cases. There will be much more than that actually. So now they have declared it is endemic. So outbreaks keep happening, smaller outbreaks. So I think NIV Pune must be having RT-PCR for CCHF. And this is one of the closest differential which I thought was for Ebola or Bundibugyo virus.
Dr. Sir, I'm going to ask to unmute. You can unmute yourself. Yeah.
Actually, maybe a decade back, NIV had reported for 5, 6 cases of CCHF. I think they were trying to investigate samples of dengue and they tested for CCHF and 6 of them came positive.
Okay, sir.
This was a newspaper report that I remember. I don't know whether there was a published paper or not.
Mm-hmm.
So
There must be,
it
sir.
does occur sometimes.
Yeah, correct, sir. And one more important thing is maybe we keep looking at water surveillance from the stagnant, the water waste. That also can help us in knowing the outbreaks which happen in our country, which is very important.
Right. We have just maybe 8 more minutes. If anybody has more questions. Okay. Renurkar sir, I'm just going to ask to unmute and you can have your comments, please.
Good evening, all. Good evening, Nagvekar sir. I think Dr. Shinde already said regarding this thing. In a short span of maybe 3, 4 days only, you prepared such a fantastic talk for us. We are very much thankful to you. You accepted the invite maybe on Friday itself, and you prepared it, and you have presented it in a nice way. So almost each and every point is covered regarding Ebola, which many physicians or many of us had some anxiety how to go ahead and how to see. The most important thing I think is the travel history and the other important things which you discussed. I
Thank you,
think
sir. Thank you for the opportunity.
yes. Pushkar, over to you again.
Yes. So I think
अजून कोणाला काही बोलायचं असेल तर विचार.
yes. We have some time. Anybody wants to, if not a question, maybe add comments or any insights. काही लोक सुट्टीमध्ये मसाई मारायला जातात, केनियाला जातात. Because it is not, there's a country in between Kenya and DRC. But if anybody has encountered with people who have gone there, yes, I think we have recorded this session and it will be available for all to access. So maybe Vayambe sir, you just want to have some concluding remarks and then we can close. I'll ask to unmute just a moment.
As I said, you have discussed the details of all the Ebola viruses and the CHF also. And it was a fantastic presentation, as Pushkar and Mukund had said. Only 4 days, you have done a fantastic job. So on behalf of API Pune, we thank you from within our heart, and thanks a lot for a constant association with API Pune, and looking forward to meet you on some other topic in future also. Hopefully not for any endemic or epidemic also. So let's hope that we don't get encountered with another epidemic. Already we have so many endemic diseases with us. So let's hope that we are successful in keeping this type of virus away from India. And let's hope all the public health and all the international travelers are properly screened and the disease is kept away. So once again, thank you very much, and looking forward to meet you again. And thank you all the API delegates for attending this seminar. Thank you, Pushkar, for all the technical assistance. Thank you very much and good night.
Thank you for the opportunity. Thank you so much.
Thank you, sir.
Thank you.
I shall end the meeting for all now. Thank you.
Yeah.